Hey guys, welcome to the YouTube channel of the Stroke and Brain Aneurysm Center of Long Island. I'm Dr. Kimon Bekelis, and today Jason Wallen and I, we will be commenting on a video you guys asked us to look at.
So we have a Chicago Med
show. Okay. Let's see what this is all about. Have you actually pause this for a second maybe? Have you watched this show?
No, I have never watched.
Me neither, actually. You know, we reacted to the ER video before, and I had watched that show before I went to medical school, actually. But never watched Chicago Med, so that'll be interesting. Let's see.
No, the only medical show that I watched pretty decently, most of the seasons and stuff, was House.
Oh, okay.
Which is one of the farcical ones. But
yeah, the most unrealistic one of all.
But I would have to say the most entertaining.
I know, you guys are trying to get us to comment on that, but I cannot bring myself to make any reasonable commentary on it. All right, let's see this one.
All right, let's go.
All right, so there appears to be a patient.
Parents here?
No. She seems to be in a coma. She's not really responsive. She has a tracheostomy or a breathing tube placed in her windpipe to allow breathing.
Yeah, well, I don't think it's the right thing.
So I think they're talking on somehow, and this is messed up, but I think she's pregnant. And
okay.
And the parents are going to keep the baby. I don't understand any of that.
Okay.
But
so she's pregnant and she had some sort of brain injury
she was in a facility and I think something happened.
Oh, I see. So she had an old brain injury of short, and she was in the facility, and somehow she's pregnant.
Yeah, because they say horrible. For 5 years. So if people are going to do the math, they figure it out.
Yeah, that's horrible. Now, while you have it stopped, let me say, this is common. If you have a significant sort of brain injury, if you have a stroke, bleeding in the brain, or even trauma in a car accident, and you're incapacitated and you're not awake enough to keep your airway open, you cannot really breathe on your or actually maybe you can breathe on your own, but you cannot, you don't have the level of alertness to keep your mouth open, and your airway and everything else, and your tongue possibly will fall on top of your open airway and close it. In those cases, they cannot really remove the breathing tube because you would, of course, suffocate. In that case, what they do is they place another tube inside your windpipe, what we call a tracheostomy, and you see that that's in her trachea. Now, if she's been injured for 5 years, I would anticipate that to be out, to be honest with you. So she appears to be breathing on her own fine. She doesn't have any assist devices. Mm-hmm. She doesn't have the tracheostomy connected to a ventilator. That would be a situation where if somebody now has a tracheostomy, of course, so you take out of the equation the concern of mental status obstructing somebody's airway. If their lungs can function independently and they can breathe on their own, that is, of course, a situation where eventually you don't need possibly the tracheostomy and you're able to remove it. In her case, it appears to be there for 5 years, so maybe a little too long, but who knows what other conditions apply here. And it almost seems to me that there's a cap on the tracheostomy, meaning that, possibly it's not necessarily used for breathing. Sometimes you cap the tracheostomy to get people to talk. I don't believe she's talking. But anyway, so that's kind of some observations. Who knows what the thought process is behind that. Anyway, let's see more.
All right.
Maggie. Did you see that? Mm-hmm. I know PVS patients do that, and it's just a reflex, but didn't it seem like there was more going on?
So here we see she called her name and the patient blinked. That is very important for, I think, what I think they're getting at further down in this clip. But the way our brain is structured, of course, we have the majority of the brain being the cortex, where we do higher processing and higher function, where we think and we move and we have all the higher integrative functions in the brain. And then we have the brainstem, where there's a lot of reflexes. The brainstem is the part of the brain that connects the top part of the brain, the cortex with the spinal cord. And in the brainstem, you have a lot of the reflexes of the face, of the eyes, of the mouth, and of course, breathing functions. And so that's a reflex. That's what she's saying. Or it can be voluntary. It's tough to know at this point, but let's see what else they'll show us.
Wishful thinking.
Teresa, can you hear me? If you can hear me, please open your eyes.
So what she's doing now is she's applying what we call noxious stimuli or pain. Typically, when you apply pain in traumatic brain injury patients or patients in a coma, you can get some reflexes. So we have ways of identifying how deep somebody's in a coma, and using painful stimuli is a substantial component of identifying how deep somebody is. So she's not just being cruel to her, it's just standard to use painful stimuli.
Teresa, if you can hear me, squeeze my hand.
She's asking to squeeze her hand. Of course, that's she's trying to see if she can follow commands. She was under the impression maybe she followed commands with her eyes a few seconds ago, and now she's trying to see if she can do more, so more higher level function. So let's see. She doesn't seem to be responding to that, of course.
No.
My time at the vent farm, I've seen this a lot. Blinking, spasms, sudden jerks of movement. Never ends up meaning what you want it to.
Let's get a CT brain,
On a 5-year coma patient?
just in case.
So she wants a CAT scan of the brain. I don't think that's going to be very helpful at all, actually.
I was going to ask, what would be the benefit of doing a CT brain?
Zero. There's no benefit here. When you get a CAT scan of the brain, and we had a video on CAT scans and MRIs of the brain, but a CAT scan is a very basic way to look at the brain. It's not very detailed, and it would be extremely useful in situations where you have an acute change. Something changes rapidly right now. You want to see, is there a bleed? Is there a stroke happening right now? For old established problems, a CAT scan is not really going to be very helpful. So, I think it's the sake of dramatization.
Would an MRI be of use at all?
I don't think an MRI would be of use either, honestly, because presumably this patient has had issues for a long time, and they've had multiple CTs and MRIs, and you kind of know what their brain looks like. And that I don't think there is a new change, at least a change for the worse for her. So what are you trying to see? Of course, you would get an MRI or a CAT scan if, say, something changed for the worse, and in that case, you would need it to get an understanding of what changed. In this case, maybe she's wondering whether the patient is more awake than they believe the patient is, but imaging is not really going to help in anything.
So it's more for drama.
Correct.
Hey, you discharging her?
Just finish the paperwork now.
So she's going to a long-term care facility.
Yeah, that makes sense.
Dr. Manning?
Yes.
And this whole thing is in the emergency room of Chicago Med. Is that the premise?
It seems that way. Yeah, I guess
Okay.
she came in. I guess they never roomed her.
Right. And so now I know you stopped it. So I see from the jacket of this gentleman, he's the neurosurgeon, I guess, on call. So let's see what this guy's going to say.
Yeah, and from the clips that I saw, he is like the neurosurgeon component of the show.
Yeah. The hospital has one neurosurgeon.
Well, he's the chief, of course.
Yeah. Okay.
It does everything.
Your coma patient, given the abysmal treatment she received at that facility, I couldn't help but wonder what other ways they might have failed her. So I reviewed her history.
Did you find anything?
I'm afraid not, but I do have one question. What time of day did you perform that neuro exam?
Morning. Why?
Well, sometimes traumatic brain injuries results in a patient developing irregular sleep-wake circadian cycles. So it's possible Teresa's become nocturnal.
Yeah. So that's not realistic. Can your sleep cycle be disturbed after traumatic brain injury? Absolutely. You do not become nocturnal. You do not turn into a vampire. It's not something that happens. Somebody doesn't elect to not respond during the day and respond at night.
I mean, I've never met somebody who wouldn't wake up.
No,
because
so
it's
that's just completely off the reservation.
We try the test again.
Great.
So they're doing another neuro exam to test his theory.
Chief of Neurosurgery. Do you mind if we perform one more test on your daughter?
It's for
Well,
parents.
the EMTs from our new facility are on their way.
It should just take a moment.
Teresa, if you can hear me, please open your eyes.
Just try to see again for a response.
1,000,000 times. I know. Just bear with me a moment. Teresa, if you can hear me, please move your eyes side to side.
She's asking to move her eyes side to side.
Would there be any reason why she's cross-eyed?
I finished
Yeah,
Teresa's
I mean,
discharge. As soon as her
when,
transportation arrives, we will get you.
She has what we call disconjugate gaze. So if you don't have higher cortical function, sometimes the eyes are not going to be necessarily midline.
Okay, so that's kind of true to form then.
Yeah.
There's a condition called locked-in syndrome. If your daughter has it, she'd be conscious, but she wouldn't be able to move her eyes side to side. She could, however, move them. Well, let's see.
Yeah. So what he's doing now is, which is hard to believe that in 5 years of this poor girl getting exams by neurologists and neurosurgeons, nobody really identified this problem, but he's trying to see if she has what we call locked-in syndrome. Locked-in syndrome means that you perceived in the outside world as being in a coma, meaning unresponsive, not understanding your surroundings, but really you're 100% in there, but you cannot move your arms, your legs, your mouth, so you cannot really communicate with the outside world. The only thing you can do is some movements of your eyes or your eyelids. And in that case, of course, I would say it's a horrible fate. Probably a fate worse than death for some folks. It's really something that us in neurosurgery are fearful of for ourselves. It can happen for many reasons. It can happen because of a brain tumor, a bleed, a stroke, whatever will injure the brainstem, but will preserve the higher part of the brainstem and allow for that communications through the eyes or through blinking, there is a famous story about a French journalist who was locked in and was able to eventually write a book. They didn't really write the book, but communicated the book through blinking of the eyes, and was talking about their experience in that state. Really horrible. And actually, if anybody's interested in that, I think the name of the book is The Diving Bell and the Butterfly. Really depressing state to be in. So he's checking for that now. He's going to give her a command and see if she responds by using her eyes.
So you can only use your eyes.
Yes.
That's it.
And most of the times just blink. But yeah.
That's horrible.
Yeah.
Teresa, I need you to move your eyes up and down for me, please. Up and down.
Did you see that?
What was that?
Teresa, if you can hear me, please move your eyes up and down again. Oh my God.
So now they're fairly certain that that's what's going on. She's following commands. She's moving her eyes. So now let's see. And our eyes have a lot of different nerves that control their movement. And some of those motions are lower down in the brainstem, where if you've had an injury, these would be gone. So most of the nerves controlling the eyes would be incapacitated. But generally speaking, the third nerve, which is kind of high up in the brainstem, would be the one that'd be functioning. That's why you'd still be able to do some of the higher functions, like the blinking and whatnot, and maybe moving up and down.
And that's the extent of it. That's
Unfortunately,
really horrible.
Yeah.
And the fact that this is a real condition.
Yes, uncommon, but very, very real.
I mean, out of all of the stuff that we watch on TV and stuff like that, they come up with mumbo jumbo, and this is a real thing that we do see.
Yeah. So when we started training, when I started training, at least, one of my attendings, one of my mentors that was more philosophical in nature, he mandated that we read that book, The Diving Bell of the Butterfly. Short book, but very powerful for us to understand, when we enter neurosurgery, and a lot of us, feel that, we've achieved something spectacular, and there's a lot of arrogance involved in human nature, right? That book humbles you and kind of gives you a different perspective when you deal with these patients that, they have a fate worse than death, and you've maybe done everything to help them, but they end up in that condition. So I don't know what the right answer is for these situations. I think they're very individualized, but certainly, it humbles a lot of us.
I mean, that's why, even when we train new staff, we always say if it's a basilar artery occlusion,
right, prepare
to treat the stroke.
Right. And what Jason is really saying is that so when we treat stroke in our field, there's strokes that can happen anywhere in the brain, but the stroke that can happen in the brainstem, which would result in this condition, is the most devastating one, because either the patient will die or will end up in a situation like that. And that artery that feeds the brainstem is the basilar artery that Jason mentioned. So if that's blocked, generally we have some time frames based on which we try to open blood vessels. But because the outcomes of a basilar artery occlusion are so horrible, those timelines are not as strict in that case. So we might push the limit when it comes to that, because the alternative is obviously horrible.
I don't understand. How did you wake her from the coma?
I didn't, but I don't believe she ever was in a coma.
What?
So what he's telling them now is that, she was always conscious of what was going on. She just, folks really didn't understand that she could communicate. I find that hard to believe, honestly, that she's been through some medical professionals and nobody really spotted that. Like I said, of course it's an uncommon condition, but very well understood among medical professionals. So I think that's a bit for the sake of the show, but
also nobody ever saw her and voluntarily move her eyes.
Right, right. Which you would attempt multiple ways.
In 5 years, I would hope somebody would have picked it up.
Multiple neurologists, neurosurgeons, I'm sure.
Yeah.
But it's my opinion that her accident caused a stroke to the brainstem, which occluded the basilar artery.
What does that mean?
So that's what they're talking about now.
Completely paralyzed, but still conscious. Locked-in syndrome. She's awake, but locked in her body.
Yeah, so
she seems a little too happy.
Yeah, her demeanor is totally off here. I mean, I'm not sure this is news that you want to deliver to anybody. Of course, I guess it's to some extent, good news for the family that in spirit, their daughter is there, but the amount of suffering that she must have gone through in the last 5 years, I don't know that it's cause for celebration by any means.
No, and her prognosis is not.
No, I mean you're always in that state. The person that wrote that famous book actually died of a pneumonia. You really cannot help yourself in any way, and you can develop infections. You can develop pulmonary embolus and other ways to die. And so it's not, and you cannot do really much. You're dependent on your family and others to be with them. So it's a horrible, horrible, horrible fate.
Yeah, so her attitude's a little bit off.
A little off, yeah.
All these years? She's always been awake?
Yes.
She heard everything we said. I said.
And she was conscious? While some monster assaulted her?
Oh yeah, that's horrible. Yeah, I mean,
I know, it's so terrible.
That's
I'm
bad.
so sorry. But at least you haven't lost her.
It's possible that some of her paralysis is the result of spasticity, and it's therefore treatable with muscle relaxants and physical therapy.
Will she get better?
She'll never be fully functional, but she
Uh,
should.
She would not get better.
I mean, that's the whole thing. That
Hey, it gives it a little positivity here, but she would not get.
yeah, they're just trying to put a positive spin on the.
I wish it did, but anyway.
Regain some movement.
We can also order an infrared eye tracking device that'll allow Teresa to communicate through a computer.
Communicate.
And she'll be able to put together words and sentences.
That's
You'll
possible.
be able to have a
Yes.
conversation with your daughter again.
Conversation
And good news, but doesn't need to be that happy about.
Yeah.
with my little girl.
Thank you.
We'll give you time alone with your daughter now. Thank you.
Yeah, the neurosurgeon appears to be socially awkward, which is not uncommon. But yeah, I mean, listen, I mean, overall, I think I would. This is one of the most realistic depictions of locked-in syndrome that I've seen. Of course, there's a lot of inaccuracies when it comes to I guess, how plausible it is to be in that setting, especially with how medicine works in the U.S. these days. You know, this would have been picked up a lot earlier. But in any event, I think it kind of sheds light to a less understood and less well-known problem, and certainly gets people thinking. So I would say kudos to them for bringing it to the forefront. I would probably give this one a high mark.
Yeah, I mean, it's a disease that we don't often hear about, and
Right.
it's I mean, it's something serious, especially with the dissections that can be common, and I've seen it in younger
Blood
people.
clots, yeah, for sure. So I would say, good job on this one.
Yeah, not bad.
Super. Well, thank you guys, and hopefully we'll see you soon in one of our upcoming videos. Take care.